Good afternoon, good evening, good morning, everybody. My name is Sandro Galea. I have the privilege of serving as Dean of the Boston University School of Public Health. On behalf of our school, welcome to this public health conversation. These events are meant as spaces where we engage with issues of consequence for health. Guided by expert speakers, we come together to discuss, debate, and sharpen our thinking about the ideas that shape a healthier world. Thank you for joining us for today's event. Thank you too to the many who make these conversations happen. In particular, thank you to the Dean's Office and the Marketing and Communications teams, without whose efforts these conversations would not take place. There are more than 220 million migrants living in countries where they were not born worldwide. If migrants were a country, they would be the world's 5th largest country. Looking at the US, over 40 million people living in the US were not born here. I happen to be one of them. There are more immigrants in this country than in any other country. Each year, over 1 million more immigrants arrive in the US. And the issue of migration has long been a political flashpoint in this country, as it has been in many other countries. The US is a country that on the one hand has welcomed migrants, and on the other hand has gone through periods of demonizing and excluding migrants. And often lost in this political jockeying is the human element of the migration discussion. When we talk about migrants, we are fundamentally talking about people, not political abstractions. With our new book, Migration and Health, co-edited with Drs. Catherine Edmond and Mohamed Salman, it has been a privilege to work with colleagues with a goal towards refocusing the conversation on the people and communities affected by migration. Today, we are joined by some of these colleagues who contributed to this book for a discussion about how we can best support the health of the people at the heart of this issue, the migrants and their communities in both their home and host countries. I am delighted that moderating this event is Migration and Health co-editor, Dr. Mohamed Salman. Dr. Zaman is a Howard Hughes Medical Institute professor of biomedical engineering and global health at Boston University. He also serves as director of Boston University's Center on Forced Displacement. In addition to 5 books and over 130 peer-reviewed research articles, Dr. Zaman has written extensively on innovation, refugee and global health in newspapers around the world. His newspaper columns have appeared in over 30 countries and been translated into 8 languages. He has won numerous awards for his teaching and research, most recent being a Guggenheim Fellowship for his work on antibiotic resistance in refugee camps. On a personal note, it was really a privilege working with Dr. Zaman and Dr. Edmond on this book, and I very much look forward to hearing from Dr. Zaman today, as well as from all our speakers. Mohamed, welcome. Over to you. Thank you for joining us.
Thank you so much. It's a real pleasure to be here. Thank you, Dean Galea, for the introduction, for the wonderful opportunity to work with you and learn from you, as well as many of our co-authors who are here today. As Dean Galea mentioned, my name is Mohamed Salman. I also happen to be somebody who was born outside this country. I also grew up in Pakistan at a time when there were millions of Afghan refugees in the country. That situation hasn't changed in about 40 years. In many ways, the xenophobia, the politics of exclusion, and the lack of attention to health has only become worse. As the director of the Center on Forced Displacement at Boston University, our goal is to bring scholars, practitioners, researchers, activists, authors, writers, and the general public in addressing these challenges in a way that is ethically grounded, rigorously supported, and based on evidence. So it is my absolute and distinct pleasure to be here today and to be moderating today's discussion. Now, I would like to introduce our speakers for the program and also just give you a sense on how the program will move forward. First, we will hear from Santino Severoni. Dr. Severoni is the director of the Global Health and Migration Program, Office of the Deputy Director General at the WHO in Geneva. He has over 24 years of experience as an international senior technical advisor and executive, having worked for WHO, governments, NGOs, and foundations in East Africa, Balkans, Central Asia, and Europe. Second, we will turn to Marie Noordam. Dr. Noordam is a professor with special responsibilities in the section of Health Services Research at the University of Copenhagen, Department of Public Health. Professor Noordam's scientific main interests lie within the field of equity in health, migration in health, and health services research. A particular focus is on the impact of ethnicity and migration on health conditions and access to healthcare, vulnerable migrants group, mental health, and chronic diseases among migrants. Third, we will hear from Aisha Kadir. Dr. Kadir is a pediatrician and senior humanitarian health advisor for Save the Children. She works in the clinical care, public health research, health policy, and advocacy. Dr. Kadir's clinical work is in pediatric emergency medicines and social pediatrics in Europe and in humanitarian settings. Her research, advocacy, and policy work focuses on the effects of migration, armed conflict, and other forms of violence on children and families and in finding effective ways to protect and promote children's and families' health, well-being, and rights. Fourth, Joshua Breslau will present. Dr. Breslau is a senior behavioral and social scientist at the RAND Corporation, whose work focuses on social and cultural influence of psychiatric disorders and their treatment. An anthropologist and epidemiologist with over 2 decades of research experience, Dr. Breslau's research examines racial and ethnic disparities in risk for psychiatric disorders and treatment use, life course consequences of psychiatric disorders, and impacts of policy and treatment of people with behavioral health conditions. Finally, we will close the presentation with Dr. Sanal Liu. Dr. Liu is a professor in the Department of Bioethics at Case Western Reserve University School of Medicine in Cleveland, Ohio. She holds secondary appointments in psychiatry and global health at the School of Medicine and Social Work at the Mandel School of Applied Social Sciences at Case Western. Dr. Liu has been serving as editor-in-chief of the Journal of Immigrant and Minority Health since its inception, and prior to joining the faculty at CWRU, she practiced immigration law for 14 years, focusing primarily on deportation, defense, and health-related immigration. Once all of our speakers have finished their presentations, we will begin our panel Q&A discussion. I would like to ask our audience to please submit your questions through the Q&A feature on Zoom, and I will ask our panelists to wait until our discussion to answer those questions. Dr. Severoni, over to you.
Thank you, Professor Zaman. Thank you, Dean Galea, for having me with you today, and for the pleasure and privilege to contribute to the book. I firmly believe in that our work is supposed to be even more targeting undergraduate or senior students into PhD or postgraduate type of training to better understand the public health issues related to migration. And this not only for public health students, but also for experts. We believe that also those healthcare workers involved into clinical work sooner supposed to have a bit of more background and knowledge on this important and complex topic. Today, I put together a few slides to just share with you the recent findings we collected from the first World Report on the health of refugees and migrants. The findings observed have been somehow confirming our feeling that progresses are ongoing, but more need to be done in terms of really strengthening the capacity of the health systems of our member states to respond to the public health needs of this population. If you look at the magnitude of the phenomenon, indeed, we cannot underestimate the importance that the challenge faced by the population. We're talking about 1 billion of people on the move nowadays if we count the international migrants, internal migrants, displaced, refugees. So certainly the public health challenges and the health outcomes that can interest this population must to be an important element of consideration for planning and service shaping by the health system. The report also showed that progresses are ongoing, but more need to be done. We are just probably at the beginning of seeing a more modern, more attentive inclusion of this population in the effort of the health sector. So far, the most common attitude of the health sector around the world was to consider the health implication of population movement as a sort of side effect of the migratory process. And this is not the case. Health should be considered as a founding element to ensure health and well-being of all population, including those on the move. And it was interesting, the confirmation and let's say, discover that the World Report showed to us the necessity to continue to work in addressing the root causes beyond the public health challenges faced by this population. The need to really urgently reorient existing health systems with an integrated approach, with a multi-sectoral approach with a people-centered approach with a primary care and universal health coverage consideration. Not showing tiredness to keep advocating and investing into education and public education. The necessity also to invest more into research, quality research, particularly at country level, in order to better understand the phenomenon and the manifestation on the ground, but also in starting to systematically collect data, disaggregate data, and using those evidence, those data for policy formulation to support health authorities in taking decisions. In order to accelerate, or in order to support those needs identified by the report and by other research we have been conducting, the global program on health and migration here at WHO invested into 5 strategic direction or main area of engagement. We call them core functions because we believe those to be essential area of engagement if we want to see progresses. The first core functions, which we believe extremely important, is really investing into global leadership, high-level advocacy, coordination, and policy development. This is extremely important, and as today, we are just the day after of an historical happening. The executive board just 48 hours ago approved the extension of the WHO Global Action Plan on promoting the health of refugees and migrants. This is very important because it's been supporting, inspiring, and guiding the work of WHO and member states. This is the second term. Let's say we had the first 5 years of implementation. We conducted a review of progresses ongoing at country level, and it's quite encouraging, quite overwhelming to see that the number of countries better understanding and deploying resources and commitment in this area of work are on the rise. We also publish, in fact, a compendium of country practices. We received so far, this is a living document, we received so far 94 contributions from all around the world, where we extrapolated 48 cases, really confirming that major changes are ongoing. Although the progress at country level need to, this might sound as a surprise, but need to be accompanied by changes and adaptation, resilience of us, of our organization, of WHO. As I said before, this topic was in the past touched upon in the frame of other cross-cutting issues, but never really supported in a systematic manner. Today, the global program is proud to work with other 6 teams in each region of WHO, and the results are visible because things are developing as we speak with a regional policy in place and commitment in support to the member states. The second area of engagement, and this is extremely important, although it was surprising to see that so little was done in the past also by WHO, was to invest into a core function of the organization: norms, standards, production, and research. In reality, very little was available, so we engaged into a quite important process of recasting the existing knowledge and norms in order to take into account the complexity and the specificity presented by the population on the move and the intersection with a functioning and the service available in the health sector. But also we feel important to invest into a modern, updated, and effective research. The research agenda, as I'm speaking, is ongoing, and we are planning to complete this piece of work by the summertime and to publish at the falls. And the research agenda aim is to really provide a framework to academic institution and to extend collaboration with academic institution with a particular attention to North-South collaboration. So far, we are observing that majority of research ongoing worldwide is about reality in low and middle income settings conducted by academic institutions in high income setting. We want to change this trend by involving more and more also academic institutions in low and middle income setting and pairing them with an academic institution very well known and capable in high income setting. The healthcare workers are, of course, for us, a central element of interest and support. That's why also recently we released the global competency standards, and at the moment are under implementation process in a number of countries, because this was a caveat existing in managing the healthcare workforce worldwide, and this is essential to really support and shape up the future healthcare workers able to deal with a complex reality of migration and with a changing demographic, which is nowadays interesting all countries. For a phenomenon which too often was wrongly perceived as an invasion or as an unmanageable phenomenon, reality, this is something which is accompanying our life, which need to be managed in a wise, proactive, and organized manner. The third area where we are investing is monitoring trends, strengthening health information system, and developing framework to measure our progress, our impact at country level. This is extremely important. As I say, when I started my work in WHO, the availability of data, the availability of evidence to support any sort of technical speculation in order to also advise member states was extremely poor, was extremely insufficient. So this is going to be a central part of our effort for the coming few years. And the report which I mentioned at the opening of my intervention is the first report of this kind, and we are planning to periodically issue a report more and more based on data, on fresh data that going to be analyzed and utilized to provide as much as possible a reality picture of the situation. The current report was having the challenge that been produced through support of really a large team of collaborator, academic institutions, UN agencies, and experts and consultants, but usually based only analyzing the existing evidence. So this was posing quite important challenge in terms of comparing the results, in having a full picture, complete picture of the reality. But however, very useful to draw a baseline picture to identify the most urgent area of interventions that I showed you a few minutes ago. The next area, the fourth area of engagement, is country support. We do believe that what we do, where we are investing energy and work, if it's not useful at the country level, it's useless. So the collaboration, support, and work with countries is really central in our daily activity. We have taught a number of initiatives. We have put in place a number of technical assistance plans. There is a massive production of guidance and technical documents to support the member states, also training or in-country activities to really move on the agenda on health and migration. But I like to mention a flagship of our effort, which is the Global School on Health and Migration. The last one, last December, was conducted in Bangladesh, previously in Jordan. We tend to rotate in different regions. It is becoming a very important appointment where the academic world, where the expert, where the government representative, usually policymaker, decision maker, manager. So the important part of the government, which is hands-on in shaping up the services and the health systems response to the health needs of migrants and refugees, they're usually attending. So far, we have trained more than 5,000 people through the global school. The last area, it's represented by the engagement with partners. As everybody can easily understand, health is only one small piece of the topic of migration. However, health is heavily influenced by what other sectors are implementing. And that's why for us it's extremely important to have a close collaboration with key partners as the International Organization for Migration and UNHCR. We are having not only regular collaboration, but also WHO is actively involved and engaged into the UN network established by the Secretary General to support the implementation of the global compact on migration, while my colleagues from the emergency department, they are fully engaged in working with UNHCR in support of the implementation of the global compact of refugees due to the prevalent nature of preparedness and emergency situation around this group of population. I'm stopping here and happy to have shared a bit of our work, but just to give a census of the engagement and priority that we are devoting to this area of work, and looking forward to questions or request of clarifications later on. Thank you so much.
Thank you so much, Dr. Zavaroni. Really appreciate the perspective and also the programs. I think they're of great interest, especially the schools that you mentioned, and sort of developing a global scope and understanding of these issues. Thank you so much. Next, we turn to Dr. Marie Nordem. So over to you, Dr. Nordem.
Thank you, and thank you very much to the organizers for inviting today, and also for inviting us to contribute to the chapter. I'm going to talk briefly about migrants' access to healthcare, which reflects the chapter that we have also contributed to. And the next slide, please. So, access to healthcare for migrants is central throughout the migration process, and is also challenged throughout the migration process. So right from the beginning in countries or areas of origin where conflict, collapse of healthcare systems, lack of access to medicine affects migrants. And also during the journey, of course, the same factors with lack of access to care, to medicine, to food, water, etc., may affect care and health. And then these factors may also spill over together with the factors in the immigration countries that I will talk more about that affects migrants' access to healthcare. Next slide, please. So when we talk about access to healthcare for migrants, we generally use two conceptual frameworks. So one is to talk about equity in health. And equity in health, as stated by Whitehead, implies that ideally everyone should have a fair opportunity to attain their full health potential, and more pragmatically, that none should be disadvantaged from achieving this potential if it can be avoided. And to obtain equity in health, we sometimes have to treat people differently. So it can be in case of migrants to provide special services for some groups, or it could also be in case of other population groups. So that's one framework that we often use. Another framework is a human rights-based framework, where we have different declarations and conventions stating access to healthcare and to medicine for all individuals. And we also have more specific conventions alluding to children, to labor migrants, to refugee groups, etc. And as former UN High Commissioner for Human Rights, Mary Robinson, stated, so the right to health does not, of course, imply the right to be healthy, but it does require governments and public authorities to put in place policies and action plans which will lead to available and accessible healthcare for the entire population. Thank you. Next slide. And just to say, when we talk about barriers and access to healthcare, we sometimes talk about formal and informal barriers, but we can also talk about legal barriers, or they're quite identical to formal barriers, and about structural barriers and individual barriers. And I'll just touch upon these different types of barriers. So talking about legal barriers, they especially allude to groups like asylum seekers and undocumented migrants who are limited in their legal rights to healthcare. This study is a couple of years old from the European Journal of Public Health, which studied access or healthcare entitlements for child migrants in Europe and Australia. And looking more specifically at asylum-seeking children, the table here shows that only 5 of the countries studied, so to speak, gave same legal entitlements to asylum-seeking children as to native-born children. So we do indeed see some discrepancies here. Next slide, please. Then there are also structural barriers, and of course they are more related to the organization of healthcare services. So it could be user payment, or as recently introduced in Denmark, for instance, also as part of user payment, a fee on using interpreters if you've lived more than 3 years in the country. It can also be more structural racism or discrimination in the healthcare system, lack of interpreters and indeed qualified interpreters. Can be lack of special services like rehabilitation services, and also it can concern healthcare professionals' attitudes to patients with migrant background. The last kind of barriers I want to mention is individual barriers. So they are, of course, related to the individual migrant and, so to speak, concern what we all carry of luggage and characteristics with us. So it can be language barriers, it can be newness. So how do you navigate a system when you're not used to how it's structured? You're not used to maybe the role of the healthcare professionals and how they act compared to what you have previously experienced. It can be health, lack of health literacy, so awareness of diseases and bodily functions, etc. Illiteracy, marginalization, can be vulnerable financial situations, and also kind of the general stress of living transnational lives that may affect how you access care also. Next slide, please. I think there's another one. The next, yeah, thank you. So to overcome these different barriers and to promote access to healthcare for migrants, I think it's really important that we have migrant-friendly healthcare policies, of course, and also that we know that some immigration policies that are not health-related may indirectly also affect migrants' health. Then it's also signing of international conventions that need to be reflected in national law, which is really important, of course, especially for the vulnerable groups that I also mentioned before, like children, asylum seekers. And of course, when we talk about these issues, it is really, as was just mentioned before, it's really important that we have strong agencies like WHO in the field heading many of these efforts, because it's united efforts of researchers, policymakers, NGOs, etc., to try to promote equity and access to healthcare for migrants. Another thing is improving the organization of healthcare services, including having separate services. It's debated sometimes, but it's also a way of empowering some groups, and it's necessary, for instance, rehabilitation for torture and trauma survivor services, etc. As was mentioned before, also improving data collection is really important, that we have data actually throughout the migration process, also data from countries of origin when possible and during the journey, and that we also collect data as far as possible on the more difficult populations to collect data on, like undocumented children or undocumented migrants. And lastly, I think another important area where we can help promote access to healthcare and equity in health for migrants is, of course, to roll out diversity competences to a much larger degree, organizational-wise, but also for our clinicians in the clinical work. You can give me the next slide. Thank you. And here on a final note, I just want to say that I think the concept of diversity competences has been used to a much larger extent in the US than in Europe, in many new immigration countries like the Nordic in Europe, where I come from. It's rather a new concept, so to speak. But it's really important that we teach our medical students, nurses, healthcare professionals, people in the healthcare system about how to work with more and more diverse populations. And of course, very often it's mentioned here that it's a three-legged concept. It's a concept that requires knowledge about risk factors, disease patterns, etc. It requires knowledge about attitudes, being able as healthcare professionals to reflect about your own implicit bias, your tendency, or all of us have our tendencies to stereotype, etc. But that we are able to reflect about this is a first step about privileges, power structures, etc. And then skills is the last leg, which is, for instance, being able to, in the clinical work, to cooperate and know the framework for working with an interpreter, among other things. So that was actually all I wanted to give of a brief introduction to migrants' access to healthcare. Thank you.
Thank you so much. I really appreciate the perspective, including sort of the access as well as the perspective that you bring in from Nordic countries. Really appreciate it. Dr. Aisha Kadir, I hope I'm pronouncing her name correctly, is our next speaker. Over to you.
Sorry, I had trouble unmuting here. Can you see my screen?
Yes, we can.
Excellent, thank you. And thank you for inviting me, and especially thank you for ensuring that the discussion will include a focus on children. So what I would like to use this time to do is really to discuss why we should be paying attention to the health needs and the risks of children who are in migration situations, and also why we should engage with children to better understand what they're experiencing and what the priorities are. Children are more likely than adults to be affected by, to be forcibly displaced from their home. They account for 41% of forcibly displaced people, but they're only 30% of the world's population. And the vast majority are living within their own country or a neighboring country. Most of them are in low and middle income settings, and many are fragile, conflict affected, or vulnerable settings. And among, more generally, among migrants who've crossed an international border, 1 in 8 are children. Migrating and displaced children have specific health needs and health risks, which I'll touch on in a moment. But a couple of particularly vulnerable and also less visible groups that are important to mention include unaccompanied children and children whose parents have migrated. So unaccompanied and separated children are either traveling alone or they've become separated from their caregivers or families. And we only have estimates for the number who've been registered with authorities at some point. This number is 153,000, but it's really thought to be a significant underestimate because of low reporting rates and because many of the kids don't ever come into contact with authorities to register their presence. Another particularly vulnerable group are children who have one or both parents that have migrated somewhere else. So these children may be left in the care of a single parent or a family member or a friend or a neighbor. And they're more likely to face barriers in access to their basic needs, and especially to education and to healthcare. And as with other children in migration situations, we really don't have sight of them. Probably one of the least visible groups of kids. Most of the figures come from China and India, but the phenomenon is well known across the globe, very broad. And I think many people in this webinar may either know people who at some point have been left in the care of somebody else while one or both parents have moved, or maybe have been so themselves. Before we talk about what we know about the health of migrant children and the risks, it's really important to be clear who we're talking about. And I make a point of this because it really is a challenge. I have on the slide here, I've got a definition from the UN Convention on the Rights of the Child, which states that a child is every human being below the age of 18 years, unless the law in the given country says otherwise. So it's actually up to individual nations to define who is a child, and it's very focused on chronology, the chronological age. And then depending on what lens we look at, like for example, an adolescence now is most commonly defined as 10 to 19. If you're looking at violence against children, you'll see another grouping. There are many different ways to define a child. However, so why is this important? Well, if you want to understand what kinds of health risks and health needs that migrant children have, it's really important to think about what childhood is. And so we can see the human being and whatever needs and vulnerabilities they may have, as well as the protective factors. So if we're going to promote child health and to protect children, then we really have to be able to see them and also to listen to them. I think everyone agrees now that a person's health early in life has measurable impacts later on. And so we've seen a shift globally towards a life course approach to health and to public health. But for children, this is especially important because they go through some pretty extraordinary transitions in a very short period of time. And I'd like to ask you to take a moment to consider the differences between a newborn child, a 15-month-old, a 6-year-old, and a 15-year-old. They're really very different. And not only their physical size, but also what they can do and how mobile they are and how they communicate. And they go through some quite significant changes in the way their bodies function, and they have a profound process of cognitive, social, and emotional development. And all of these factors play a role in how they understand themselves and also the world and how they engage with their surroundings. And all this time, while their bodies and their minds are developing, their identity is also developing and changing. And their identity, their understanding of themselves is determined by their health, of course, but also their understanding of themselves impacts their health. So it's quite a circular sort of a bidirectional process. And the way people and the environment engage with children is very different when they're at different stages of growth and development. And this doesn't always correspond to their chronological age. And so when children move place, this introduces another form of transition that influences all the other continually changing and developing aspects of their lives, and also their bodies and also their identities. Life is upended and the environment changes. Everything is new and foreign, and they may become separated from their caregivers, their family. They may not understand the language. They may witness some of the worst of humanity and hopefully also some of the best. And I think Professor Nerdam touched on quite a few of the barriers that children are particularly vulnerable to. The key thing to remember is that whatever age or developmental stage, children are actively participating in their lives. They have thoughts and understandings about what they see and what they experience. And the way they make sense of the world influences how they behave, how they interact with it. And that impacts what kinds of health and safety risks they may face going forward. So the health risks are related to the conditions before they move and during the journey and after arrival, but how they understand everything that's happened and how they've experienced that has really important effects on their health and their needs and their health risks and their well-being. So we have to see them. And we also have to listen to them to understand. And we have to try to understand what they've experienced and how they make sense of it. Because if we do this, then we have a much better chance of meaningfully protecting them and promoting their health. So this last slide is very much an oversimplification, seeing as how there are so many different phases that children go through. But the point it intends to make is that the most common and the most important health needs of children at any stage of the journey are the most common ones are social in origin. And so access to basic needs and a safe and secure environment, participation in school or daycare, and support for caregivers to optimize caregiver health and well-being are some of the most important factors. It goes without saying that access to appropriate and informed pediatric healthcare is is important as well. But community acceptance, especially, and a sense of stability have been shown in numerous studies to be protective. And studies in Scandinavia have found that children and young people who perceive discrimination have significantly worse long-term health outcomes compared with migrant children who felt that they were accepted by their community. So when a supportive social and educational environment is in place, then children have the best chance of adapting positively to whatever they've experienced and to their new environment. On the other hand, if we don't put these social sort of protective factors in place, then children are at high risk of injury, physical and psychological illness, worsening of any existing health conditions they may have, as well as trafficking, exploitation, and death. And so I'd like to conclude by bringing our attention back to the continuous transitions throughout childhood and adolescence and the importance of children's perceptions and understandings of their health risks and of their behaviors and their health outcomes. Children account for a large proportion of migrants and refugees, and they are among the most vulnerable. But if we engage with them and if we provide appropriate support, then we have the opportunity to nurture healthy and positive life trajectories, not only for the children who have migrated themselves, but also for future generations. And I will stop here. Thank you so much.
Thank you very much, Dr. Kader, for the wonderful presentation and emphasis on children that are often most vulnerable and in many cases not considered with the same level of rigor and engagement in our scholarship, in our practice, as they ought to be. We now move on to Dr. Breslau, who is from RAND Corporation. So over to you, Dr. Breslau.
Thank you very much. It is a great pleasure to be included in this presentation, and an honor to be presenting to you today and to have been included with my co-author Lillian Perez in contributing to really a landmark volume on migration and health. I'm going to focus my comments today in this brief presentation on the area of my own empirical research, which is really focused on labor migration and mental health. And in particular, I really have kind of one overarching theme or point to emphasize, which is the importance of a transnational focus in this research, and the importance of seeing migration not simply as the movement of one population to another area, but as a complex of institutions and movements of people and resources, culture, etc., that connects and ties populations across international boundaries, as well as across large distances, even within countries. So there are a lot of migrants, as has been said. Labor migration in 2019, according to IOM, there were 169 million international migrant workers. Labor migration, I think it's important to distinguish the labor migration from refugee movements. In the case of labor migration, we are not often seeing the same kind of acute crisis situations, but that's not to say that really the public health impacts are small. The public health impacts, given the enormous numbers of people who are impacted and the ramifications that these have across the broader populations in both the countries of origin and the countries of destination, are really profound. And I think we are still trying to grasp what those might be. My work focuses on mental disorders and the epidemiology of mental disorders in migration, and I'm going to be very broad and talk about mental disorders broadly, including substance use disorders, which we know mental disorders are among the highest sources of disability-adjusted life years globally. it's important that when we think about mental disorders, we're really thinking about chronic medical conditions, that they tend to begin in childhood and adolescence. So they interact in different ways with migration, depending on where in the life course a person is migrating or where they are impacted by migration. And there's a very high variability across countries from what we know and think in terms of the prevalence of conditions. And often we have migrant groups crossing boundaries, crossing into populations that have a very different underlying rates of mental disorders. So the work that I referenced, so that I was talking about, is largely part of this study, the Mexico-US Migration and Mental Health Study, which was a collaboration between researchers in the US and researchers in Mexico. And it really took advantage of a serendipitous opportunity where surveys were conducted in Mexico and in the United States using the same survey instrument at the same time, and had information on migration history in both countries, and allowed us to combine data on these two countries and look at migration in a transnational setting. So prior research really had research data in the United States and had looked at, for instance, migrants in comparison to people who were born in the United States. But we were able to look at both sides, and I think really see some processes and aspects of this overall transnational phenomenon of migration that otherwise were invisible. And this is an example, or several examples, I should say. So I realize this is a busy slide, and that's kind of the point, because each of these that I want to emphasize are kind of different aspects of this transnational process of migration that are likely to have impacts on mental health, and actually we have shown have impacts on mental health, and all of them really require some kind of transnational or cross-national data to investigate. And so we have the whole issue around health selection. So how do migrants differ from non-migrants in their mental health status before they migrate? So there we need to have information on who's migrated and the country, and information on the source population. We're of course interested in the impact of migration on migrants, so among migrant individuals in the period after they have migrated, as a period of risk. And we're interested there also in what turns out to be really critical in the Mexico-US case, also in behavior change, and in particular related to substance use and risk for substance use disorders. There is the impact of migration on families in origin countries, as was mentioned earlier. Return migration. So migration is almost never, I should probably just say, is never just about one direction. It is always in people return, having been changed or altered by the experience of migration. And in our case, the experience of coming to the United States from Mexico, of developing patterns of drinking alcohol, using drugs, smoking, and then going back to Mexico and bringing those behaviors along, and the associated risk for subsequent disorders, and as well as other health implications. And the issue that we really started with in terms of settlement in a destination country, cross-generational impacts, and there's a huge amount of research, of course, on enculturation to risk factors in the destination country, marginalization, ethnic stratification within countries. And I think this is a partial list of the various processes that really we need to have a better understanding of in order to understand really what is just probably a dizzying array of migrations around the world that is only becoming more complicated. My last slide, just thinking about implications, and I think Dr. Severino hit on some of these, and I'm glad that to see that complementing what he has already said. I think given the transnational issues, coordination of prevention and services in origin and destination countries seems to be is a huge priority. There is a great need for research, coordinating surveys across countries, mixed method studies, which is actually the topic of the chapter that we wrote for this book, and has been mentioned, the need to address multiple barriers to treatment for mental health conditions in destination countries. And I think there needs to be a special focus on mental health, where I think the barriers are larger and different than they are for general health care. And I will stop there. Thank you very much.
Thank you so much, Dr. Breslau. Really interesting work, including policy implications as well as methodological ideas there. I also want to thank all the speakers so far who have done a phenomenal job in keeping time, and I really appreciate that. Last but not least, Dr. Sanalu.
Good afternoon, everyone, and I want to thank the organizers for inviting me to speak at this conference, and also for authoring a chapter in the volume. It's a great honor to be here and to speak with you. So I'm going to be speaking sort of at the more micro level, looking at a case study of the United States in terms of policy access and outcomes. And this will reflect some of the themes that you've heard in the earlier presentations. So in the United States at the current time, there are 44,800,000 foreign-born individuals in the United States. And this accounts for approximately 13.7% of the population. Of these individuals, 20.8 million individuals are not citizens, and approximately 23.9 million are naturalized citizens. But their access to healthcare and their ability to receive healthcare is quite different. What we know, for instance, is that among children with immigrant parents, even one immigrant parent, they are twice as likely as children with two citizen parents to lack any kind of health insurance. We also know that 33% of non-citizens have no usual source of care, compared to 20% of citizens. That 32% of non-citizens have not had a doctor's visit in at least 12 months, compared to 20% of citizens, and that individuals who are not citizens, of those, 10% have gone without needed medical care in the previous 12 months, compared to 7% of citizens. So how does this come about? This comes about from our overarching policy that has really been integrated into legal features of the US system. So the overarching policy is to protect the public health, reduce healthcare costs and taxpayer burden, and to promote self-sufficiency. The attempt to protect the public health through the exclusion of individuals who are deemed to have specific disorders or carry specific diseases has been a feature of US immigration law since at least the 1920s, if not even before that. The effort to reduce costs and promote self-sufficiency is more recent, and what it has done has been to limit access to publicly funded sources of care. And although some provisions existed earlier, they have become increasingly rigid. So in terms of limiting eligibility, Medicaid has severe limitations except for the Emergency Medical Treatment and Active Labor Act, which allows emergency medical care for medical emergencies and for patients who are in active labor. That actually sounds more generous than it is, because medical emergencies are defined relatively narrowly in the law compared to what you or I might envision as a medical emergency. The Patient Protection and Affordable Care Act, also known as Obamacare, has limited the ability of non-immigrants to access the exchanges and to buy insurance. Between the promulgation of these laws, there were other statutes that have been enacted, the Personal Responsibility and Work Opportunity Act of 1986, and the Illegal Immigration Reform and Immigrant Responsibility Act of 1996, which expanded the application of public charge provisions and limited the ability of individuals to immigrate absent an enforceable affidavit of support from individuals in the United States. There are some accepted groups to these provisions, victims of severe labor or sex trafficking. This requires application for a T visa. Individuals who are victims of crime who are either assisting or willing to assist prosecutorial entities in establishing the criminal offense, a U visa, and abused non-citizen family members under the Violence Against Women Act. Asylum recipients are also accepted. This does not apply to asylum applicants, which means that individuals who are in the country and their asylum applications are pending are not able to access these sources of care. So what are the outcomes? You heard from Dr. Breslau about the particular impact on mental health. What we know are that immigrants are much less likely than US-born citizens to use medications for mental illness. And part of this has to do with the accessibility and the cost. We also know from a variety of studies that detained individuals, even those who have been diagnosed prior to their detention for mental illness, are often denied treatment and are held in conditions that have exacerbated their mental illnesses. And unfortunately, there are potential immigration consequences for individuals who are seeking care. So individuals may find that they are barred from regularizing their immigration status as a result of having obtained certain forms of assistance for their mental health. So unfortunately, there is a complex patchwork of laws that are designed to exclude individuals from the country who may have particular diseases or disorders. And this leads to a decreased access to medical services and increased adverse health effects. These laws really form a patchwork because they are found in the immigration laws, they are found in the welfare laws, they are found in state laws as well. So that even though states are permitted to provide funding for care for immigrants who would not otherwise be entitled to do so, a minority of states have made that available. And so ultimately, it's unclear whether the policy purposes of these laws are actually doing what they are supposed to do and whether they are protecting both the taxpayer and the immigrant. And I will conclude here. Thank you.
Thank you, everyone, for a wonderful, wonderful set of presentations and staying on time, sharing your insights, both from what is in the chapter and in many cases, how it has evolved since you submitted the chapter several months ago. So with that, I wanted to sort of reach out to the Q&A section and sort of ask our sort of attendees if they could type their questions. So what we were going to do was to sort of just read the questions as they appear and try to answer them live. Some of these may be sort of similar in nature. So we will be cognizant of that and not try to do that. And I would ask anybody from the panelists to raise their hand and respond as they see fit. The first question is from Madhavi. And Madhavi says, for health to be considered as a right, do we not need to transform our global economic parameters first? The focus of economic growth allows for externalities related to poor health, to the poor and the vulnerable. It appears that economic literacy on how decisions are made in the first place are the first step to implementing changes. Perhaps this is why the process is slow. Any thoughts on connecting the economic aspects and the global economic drivers that lead to migration, and hence health has a consequence of that? Anybody who wants to sort of comment on that? Dr. Savarani, please go ahead.
Well, happy to share a few considerations. I fully agree. The economic dimension is probably the most important driver for population movement. The majority of this large number being mentioned during the different presentations are economic migrants. So people tend to move mostly for searching for a better life, better living conditions. The issue is that still we have to admit the negative rhetoric about the effect of migration to the receiving country tend to prevail, and somehow hampering the political discussion to really include migration as a resource, as an opportunity into the economic debate. I think we should really do the best to link up, for example, the discussion about managing migration at the G20, G7, the Davos Forum, and all these major economic consensus. The other element for which there is no progress, despite the challenges and the reality is in many cases well known, is the fact that the tendency of all member states, all countries, to deal with migration tend to be individual, country by country. The availability to set up a partnership, a regional cooperation, a regional engagement is not yet there. And mostly because the topic remains very complex and very dangerous for politicians in charge. So they tend to touch upon few symptoms, but not addressing the root causes. I like to conclude by replying to the person that raised the question in terms of cultural development, if I can say like that. It's very interesting to listen to the last speech to the nation of Ronald Reagan. Ronald Reagan was a conservative, and might sound a contradiction to say today, well, conservative, they have a solution for migration. Well, listen to that last speech to the nation, and the content of Ronald Reagan, or the way how Ronald Reagan picturing the migration phenomenon in relation to United States, maybe today can be compared to a speech of the Secretary General of the United Nations. So something happened politically in the last 30 years where only the negative dimension, only the toxic narrative has been proliferating, and not really pay attention of the benefit of migration phenomenon, including the economic return, not only for the country receiving, because migrants are working and producing wealth, but also the remittances system, producing development at home, and so on.
Thank you very much. There are several questions. I'm going to combine them on climate change and the impact of climate change on migration. Some are directed to WHO, but there's another one as well at the bottom talking about climate change in general. I don't want to ask a specific question here because I think there are multiple dimensions, but would love to hear from speakers about the impact climate is having on migration. And also in my own area of research, some communities are unable to migrate because of climate change. They're sort of locked in because they can't go anywhere, right? Stateless communities in Pakistan and elsewhere. So there's an element of immobility as well that is connected. So thoughts on climate change, its impact, and how do we think about the health dimensions of that?
I'm happy to jump in. Yeah, so climate change is a major, and extreme weather events are major drivers of forced migration. And I think some of my colleagues can speak to other aspects of it, but in thinking about child health and well-being, it's both an impact, it's impacting people, like forcing children and their families to move, but it's also actually impacting what kinds of illnesses they are more prone to. For example, Professor Zaman just mentioned Pakistan, and in Pakistan, with the recent floods, which did displace a huge proportion of the population of Sindh, it also predisposed them to things like cholera and waterborne diseases. Also, when they end up being forcibly displaced, especially in the acute phase, what happens is they're often overcrowded, in inadequate, basically for children, they're shuffled, everything is turned upside down. Also, whether or not they're with their family, they have a huge host of safety risks because people are living often quite close to each other. And a lot of different things are happening. People are just trying to survive, and what they're doing to make sure that everybody has a shelter over their head and has hopefully something to eat. What ends up happening is children can again basically start to disappear after the earthquake in Haiti. This was well known that there were organizations or people actually going and trafficking children, finding children who'd been separated and trafficking them and then putting them up for adoption in other countries. There's so many different risks that are social risks and again health risks that are related to the extreme weather events or drought, like what we're seeing in the Horn of Africa right now. And it also impacts conflict. And so climate change can both worsen the effects of conflict, and it can the two of them can sort of synergistically force migration, and it can force also the places that people go to and the conditions they're living in. And for children, again, this is an added compound series of risks for their health and their safety, which impacts their current state of health and also all the risks in their health in their later years, both in their childhood as well as in their adulthood. Thank you.
Dr. Severoni and then Dr. Breslau.
Yeah, happy to complement because there was a specific reference to WHO. I want to clarify that no, we don't distinguish support to a population by topic or by context. Emergency are emergency. So as we are raising the concern about possible, because at this stage we are talking about simulations and possible scenarios in terms of size of population might be put on the move because of climate changes. The reality is to deal also with the existing emergencies. And at the moment, the number of emergencies generating displacement are really too many. And we are actively engaged in all of them. The issue of climate changes is that probably not so much going on in terms of preparedness, so helping the health system to be resilient, reactive, if large movement of population will start, but also, in my view, is a topic that deserves a bit more research to really help the health sector to position and to understand how to play an impactful role in managing the phenomenon when will manifest or when will be pressing the border of countries which might be interested. The last element related to climate changes, and in my view, we are too silent on this topic, is that when we are dealing with migration, with management of refugees, unfortunately, definition matters. And when we are addressing the needs of refugees, thanks to God, in many cases, we are comforted by the fact that many member states, many countries have been adopting the Convention on Refugees. So they have a national law in place to protect these people. This is not the case for migrants. So probably considering the scenario that we might be facing in the coming decades, it is time to engage academic institutions, policymakers, politicians, maybe to revise the Convention for Protection of Refugees, to extend the protection to certain population. As I'm speaking, just come to my mind the example of Kiribati, where the islands is planning to move ensemble, all the population, to a new territory. They actually already purchase a new territory in a nearby island because possibly their country will disappear in the coming year. So how this population can be protected in this context? What kind of commitment, what kind of mobilization of the internal community is available in order to step in supporting those populations, beside the humanitarian response, beside the charity, beside the compassion that might be put in place on the specific issue? Thank you.
Breslau?
Yeah, I think I'm saying the same thing, which is that the climate migration is really kind of combines some of the elements of refugee movements and labor migration, and does constitute kind of a gray area that we need to kind of think about definitions. But also, it really forces us to think beyond the acute situations and to the predictability of movements of people as a result of climate change, and the ability to, and really the need to develop solutions proactively before crises occur.
Great, thank you so much. I'm going to change track a little bit. There are several questions that I'm going to combine about mental health in the context of United States, but I think it goes beyond that as well. Can one of you comment on what are some of the challenges that are faced by migrants, new immigrants, refugees in the context of mental health, and what is available, and where are the gaps, and how do we address that? So, Sana, please go ahead.
Yeah, in terms of the availability, a part of it is going to depend on the status with which somebody enters. If someone is entering as an asylum seeker and they are awarded asylum, or they're entering as a refugee, there are actually significant resources available, very often through community mental health centers, through refugee resettlement organizations, through what would be called nonprofits or non-governmental organizations. For people who are entering without legal status, it's significantly more difficult. I can tell you that going back 4 decades ago, it was difficult, but not impossible, to find private practitioners who would donate their services to work with individuals who are undocumented, for instance, who had mental health concerns. And that probably extended for several decades, but at least for 2 decades now, it has become increasingly difficult with the shifts that we've seen in the medical care system, the requirements that physicians see so many patients within an hour that they account for all of their time, the integration of smaller practices into larger hospital systems. So for individuals who are undocumented, for individuals who are trying to regularize their status but who do not yet have legal status, it is increasingly difficult. There is always the fear, for instance, that if individuals access care through the public sector, even if they are entitled to that care, even if they have a US citizen child and that child needs mental health care and they are awaiting their own immigration regularization, that they will refrain from getting that care because they're afraid of the public charge implications. And public charge implications, what that means is that when someone tries to change their status or enter the country, they can be excluded or denied a change of status because they have relied on these public funds for care. So for that segment of the population, it's quite difficult. For individuals who have been detained by immigration, there is increasing research demonstrating that there is inadequate mental health care within those facilities. It varies across the detention facilities, but in general, it is inadequate and very often exacerbates their condition.
Thank you very much. There's a question that is specific to Aisha, Dr. Kader. Thank you for your brief and insightful presentation. As discussed, more equitable and accessible healthcare systems are critical to improving the health and well-being of migrant children. Also, supporting their successful integration into their new communities are needed. What efforts or examples do you see on this aspect?
So thank you for this question. This is, and I think this would be relevant also for the caregivers as well. There are, depending on where you look, you can see different countries will have different responses. Like in Sweden, in 2015 and 2016, they received a very large number of unaccompanied minors, but also just a large number of people coming into the country from a few different regions of the globe. And the actual, and I'm going to speak specifically to children, the actual response by the government, they kind of switched into a humanitarian response. And I say this working in humanitarian health at Save the Children, this is kind of what we dream of, is that we're not necessary and that the government is able to sort of try and take charge and respond. That's not always possible when the system is overwhelmed. However, what they have done is they've actually developed and really rolled out across the nation a program to help families. Specifically, they initially started focusing on labor, on trying to get the adults into the labor market, and they realized, hang on a minute, the well-being of basically the family, the caregivers are actually really dependent on the rest of the family, especially the children. And so if we look at children and caregiver mental health, then we can actually really promote really positive integration. And they've set up a kind of, they call them health communicators, but they're actually sort of people that are sort of buddies. Their job is to help people to understand what life is like in Sweden, to where they can go and access their basic needs, also what their rights are in Sweden, and then making sure kids are basically they parts of it are making sure kids are able to access school and follow how they're doing in school, and if there is trouble, then to help sort of put the various structures that are in place to support them. This isn't possible everywhere, and Sweden is a quite well-resourced country. Most of the migrant children across the globe are living, as I said, in fragile settings in low and middle income countries, and often internally displaced in their own nation. And there you will see also beautiful examples of communities that actually kind of rally together and welcome. They bring supplies. We also saw this again in Greece, I think, is a high-profile example, but you see this across the globe, where communities will actually sort of have compassion, basically, and welcome, recognize that people are coming, that they need their basic needs, and they'll actually try and reach out. And once you start to establish those connections and people meet people, that's kind of where, for lack of a better word, kind of when the magic can happen, because once you see the humanity of a person in front of you, it's really difficult to kind of put them in that other box. Now they're a human that's in your sphere of experience, and it's more compelling to help them and to make things easier for them. Other things that can be done are whether it's through a government or an NGO, basically setting up, making sure they have access to school, even just so another example, displaced people because of climate change. Often what we'll do is we'll actually set up, as NGOs, we'll set up, Save the Children will set up what we call child-friendly and also girl-friendly spaces, or spaces where children it's meant to be places where kids can just kind of step away from all the difficulties they've been experiencing and try to be kids. So you do various activities, but you also have people around who can kind of see, are there any risks? You have people who are trained to understand, are there any children that are particularly vulnerable, and any risks or any health needs, and you can get them plugged into that. But you also, again, they'll have, be working with people from the communities and hoping to get them sort of engaged with it, to get people to meet each other. Because that's really, at the end of the day, the last but not most important thing is that governments and media really need the rhetoric and the tone of the rhetoric and the way migrants are characterized in the press has a huge impact on how people see who's coming to their neighborhood, and that really impacts whether or not how they're welcomed, I should say. Not whether or not they're welcomed, but how they're welcomed. or not. So there are many different things that you can go from a national level to or an external agency, an international NGO like Save the Children or many others, but also communities themselves. And I think some of the most successful and really beautiful examples are actually when communities just rally around, and that's also more the long-lasting, I think, more sustainable way to help support integration and really a sense of acceptance, which is very protective for children and for their caregivers and families. Thank you
very much. Dr. Noordam?
Yeah, I just want to add actually to this about mental health in children, some areas of concern that we have recently dealt with also in research from Denmark. And one focus area, I think, here is sort of that children are sometimes double burdened by intergenerational trauma also, so by being in many ways having experienced trauma themselves, and also experiencing their parents, living with their parents. So I think that's a focus area where we should not forget, and we know that from studies that secondary trauma has an added effect on experiences of trauma. I think another important point is also that, at least being a healthcare professional, I'm also working as a clinician, you often have children as these shadows or silent witnesses that are helpers in the healthcare systems, translators, helping their parents to and fro, etc. But that is also burdensome, and we should take care of these children that we see on a daily basis in the healthcare systems. And then I also want to add as a third thing that these children are also very much affected, as Dr. Severoni said, about this discourse that has just been, societal discourse that has been toxic. And we know from research that it affects their self-images, and actually they think worse about themselves and the outcomes in their residence areas for youth than is actually the case, the factual case. But the self-images are affected by the medias. And at the same time, this youth, I think, is an incredible important group for us as researchers and as clinicians, not as clinicians, but as researchers to work with, and as health policy makers to bridge to the parent generation and to collaborate with. So that's just what I want to say in this context.
Great. I'll take one last question. I'm cognizant of time. There's lots of really good questions, but one thing that hasn't been mentioned often is IDPs. A lot of the conversation has focused on refugees and people coming to a different country, the role of local communities. And I wanted to sort of just bring that to the fore and ask if any of our panelists, and again, we're somewhat short in time, about 4 minutes left before I give it back to Dean Galea, on what can we do despite the complex politics of nation states and state sovereignty, and the fact that there are tens of millions of IDPs in need of that. So I'll start with you, Dr. Qadir.
Yeah, so this is something that I think the key thing is to recognize when countries, like, rather than have a bunch of external actors try and sort of wait and want to jump in, the key is to be aware. There's two things. One is we need to be able to see children and migrants more generally. So we have to have better understanding of where they are, which is very difficult, actually, when you think following people who are, especially if they're moving or they're continually moving. But if we know they're there, and then we can actually work together with governments to support them. So governments, usually, again, in the humanitarian sector, so often IDPs can be in camp settings, or they can be in informal sort of settings, or they can actually be in the community in private residence. So they're difficult they'll be in different places, and the way in a given context, the kinds of needs and risks they have will depend very much on what is happening specifically in that area. And I think the key is to actually work with governments to be able to see if you recognize as a problem as an external sort of group or agency or organization, then to actually go to the authorities and mention this and maybe can offer support, but the government then should be the one leading it. And that's the key. If you can support, rather than the last thing you want to do is undermine the existing infrastructure and systems. It's really trying to package bits of support in the most appropriate places, and that should really be driven by governments. Thank you.
Great. We'll take Dr. Liu's comment, and then I'll hand back it to Dean Galea.
I have somewhat of a disagreement with that because one of my concerns is with internally displaced persons who are displaced as a result of genocide. And in those cases, I don't think it is appropriate to necessarily rely on existing infrastructures because those infrastructures may in fact be responsible for the genocide. And despite the international conventions, perhaps we need to relook at those on a more global level to see what our global responsibilities are where we see this happening. And certainly there are countries that have closed their doors to individuals who are currently internally displaced, attempting to leave their countries as a result of genocide.
Great. Well, I just wanted to thank everyone for just a rich discussion. It can go on for perhaps not just many hours, but many weeks and months, really sort of unpacking these issues and learning from each other. I also want to thank our attendees who have contributed many questions, and I have to apologize that I can only take a fraction of those. That richness is both exciting but also embarrassing of how difficult it is to really navigate all these questions that are coming from our colleagues. But again, a big thanks, and over to you, Dean Galea.
Well, I simply want to echo what Professor Zaman said. I thought it was just a wonderful conversation. It's a rich conversation with content and also a tremendously engaged audience with really interesting questions. You know, I've had the privilege of working with all the speakers on the book, and I learned from you today as much as I've learned from you in your work on the book. So I want to say thank you. Thank you to everybody for being a part of this, and most importantly, thank you for what you do every day. And thank